It is advisable to study the appropriate essential anatomy as outlined in the Primer of Regional Anesthesia Anatomy before studying the single injection axillary block. The axillary block is done on the branch level of the brachial plexus. Because there are 7 branches, of which 3 are sensory nerves, this block is difficult to master and almost impossible to always obtain complete block with one single injection. The infraclavicular block is probably a better choice for hand, wrist, lower arm, and elbow surgery. It can be seen here that the brachial and antebrachial cutaneous nerves, numbers 19 and 20, originate from the medial cord, number 14. These 2 nerves and the musculocutaneous nerves in the forearm, number 22, are sensory nerves and impossible to identify with a nerve stimulator in the axilla. The neurotomes of the area that will be blocked if the radial nerve is blocked is shown here. This area will likewise be spared if the radial nerve is missed with this block. This area indicates the sensory innervation of the median nerve, the ulnar nerve, and the musculocutaneous nerve. The areas supplied by the brachial and antebrachial cutaneous nerves are indicated here. Most local anesthetic agents have been used for this block. The choice of this author is 15 to 40 milliliters of ropivacaine, 0.5 to 0.75%, of which 10 to 25 milliliters is injected onto the most appropriate nerve, and the remainder on at least one of the other nerves. Adding buprenorphine to the mixture triples the duration of action of the block, but if a long-acting block is required, it is best to place a continuous nerve block. The patient is positioned in the supine position with the shoulder abducted and the elbow flexed. The axillary artery is identified and marked. The skin and subcutaneous tissues are anesthetized after disinfection of the skin. Care must be taken not to penetrate the nerve sheaths with this needle at this stage. The stimulating needle attached to a nerve stimulator set at a current output of 1 to 2 milliamps, a frequency of 2 Hz, and a pulse width of 200 to 300 microseconds enters the skin at a slight cephalad angle next to the artery, and a distinct pop can be felt as the brachial plexus sheath is entered. The ulnar nerve is encountered in this demonstration. The needle can now be adjusted to place it in close proximity to the most appropriate nerve or nerves for the planned surgery. In this recording, the radial nerve is now stimulated. The nerve stimulator is turned down to between 0.3 and 0.5 milliamps with the needle on the most appropriate nerve. While keeping the needle steady and observing the motor response, local anesthetic agent is injected. The motor response stops immediately upon injection. This constitutes a positive Raj test and is an additional indication that the block to this specific nerve will be successful.